So I also can't tell you how appreciative I am of Dr. Kathie-Ann Joseph to come and visit us and travel across the country to spend a day and a half with us, and I think a day tomorrow with a friend locally as well. So we're glad that you made it to Seattle. Dr. Joseph and I had some heart-to-heart conversations about whether we could pull this off. She said, I'm game if you're game, and we did it, and it worked. And some of us have talked about we may have this narrow window of time where we can actually do this. We might all be shut down again in a month, but let's hope not. So welcoming Dr. Joseph. Dr. Joseph has a joint appointment at NYU. She's a professor of surgery at NYU Langone and also a professor of population health at NYU Grossman School of Medicine. Dr. Joseph did her undergraduate at Harvard. I'm going to do a little aside here relating to current events because you'd either have to be under a rock or on a trauma call at Harborview to not recognize what's been going on with the Supreme Court confirmation hearings. And I'm picturing Dr. Joseph as being an integral person who said, persevere, to Ketanji Brown Jackson, passing in Harvard Yard in the 1990s. I calculated that and could picture the two of you passing when she was discouraged as a freshman and needed a uplifting voice from a peer. And so there's nothing that I've seen more inspiring or impressive than the Honorable Ketanji Brown Jackson's managing a very tough confirmation process, an embarrassing process that she has handled with grace and integrity. So if you said persevere to her in passing in Harvard Yard, thank you. So Dr. Joseph then went to Columbia where she got her MD and her MPH. She did all of her surgical residency at NYU Langone, but did her breast oncology fellowship at Columbia. With that background, as I mentioned, she holds a joint appointment as a professor of surgery and of population health. She is also the inaugural Vice Chair of Diversity and Health Equity. It is the first such position of diversity and health equity at NYU Langone. She's co-director of the Beatrice W. Welters Breast Health Outreach and Navigation Program. And I know that a large part of Dr. Joseph's clinical and research interest is in assuring access to care and quality of care for diverse populations and those that are underprivileged. As part of that, she's also the chief of breast services at Bellevue Hospital, where I think she's led incredible programs of patient navigation with lay navigators who have helped bring education to the community and help create improved access for women to receive mammography and subsequently diagnostic and treatment. Dr. Joseph is also the inaugural medical director of a large clinical unit at Grossman School of Medicine at NYU Langone Health, and is a very important clinical role there. And more recently is been given the clinical systems lead for the Institute of Excellence in Health Equity. So those are all pretty impressive, and that's why you can see I'm excited that we got her to travel here to see us. And when I look at Dr. Joseph's research, her research has been in healthcare disparities in breast cancer patients and access to care for minorities and those that are underserved, and also management of those at high risk, with high risk patients, and particularly those that are underserved. But I know that one of the most important things that Dr. Joseph does is she's also a mentor and advisor and inspirer for many. And that's what we've seen here in our faculty supporting our residents and fellows. And I know that is a very important part of the influence that you have in the students, residents, and fellows and other faculty in your own institution. So without further ado, I want to introduce Dr. Joseph, who will be giving the 27th annual Helen and John Schilling Lecture, Achieving Health Equity in Surgery. Thank you, Dr. Joseph.
Thank you so much, Dr. Wood, Dr. Flum, and for inviting me. And I'm so excited to actually travel again and come all the way out here from New York. You saw that whole list. I had to give up some titles. So I have to admit, I'm no longer chief of breast surgery at Bellevue, which kind of broke my heart to do that because I did chief for 10 years, but I still operate there when I got promoted last year. But before I start, I just want to say how blown away I've been meeting all of you over the past 24 hours and hearing all of your presentations. I wish we had some kind of forum like this at our institution, but the level of research that you all are doing, your as residents and also as faculty, and as Dr. Wood said, the level of mentorship, I think you all should really be really proud of yourselves. So I'm going to talk about the work that we've been doing for the past 6 years in terms of addressing breast cancer disparities. In terms of patient navigation, it's something that's very near and dear to my heart. And what I like about this work is that it really pulls together the collaboration that we've been doing in terms of reaching out beyond our Department of Surgery to the other departments in the medical school, as well as beyond the medical school. And then I'll talk a little bit about some of the other work that I've been doing now with our Institute for Excellence in Health Equity. So you already got my CV, so I'll go past that. And then I'll talk about the rationale and background for the Welters Navigation Program, our mission, and then our overview, comprehensive overview and impact, our accomplishments. And then you'll hear about from some of our patients that have been benefited from our navigation program, and then our vision. So we've talked a lot about equity today and yesterday, and a lot of people confuse equity with equality, and you can have equality but not have equity. And so one of the things that when I took on the role of chief 10 years ago, 2010, actually, I guess it's now 12 years, was I really wanted to make sure that when we were at Bellevue, which is our city hospital, it's one of the largest hospitals, public hospitals in the country, was that the level of care that we were providing for breast cancer patients was the same as up the street at NYU. And so I really wanted to make sure that we had a true multidisciplinary approach, just like you all have when you take care of your cancer patients, but also access to the clinical trials and all that and supportive services that all our patients should deserve. So when you think about the role of surgery in population health, there has been a greater appreciation for the impact of surgical disease and trauma in population health. And there's an even greater impact on vulnerable populations. And so the need for surgical research to reduce disparities and healthcare inequities. And so for breast cancer, as you know, it's the most commonly diagnosed cancer among nearly every racial and ethnic group. And with over 40,000 fatalities every year, breast cancer is the second leading cause of death in women. And so while there's been better care over the past 25 years, that's reduced breast cancer deaths by up to 34%. In certain communities, not all communities are benefiting equally from these improvements. And so what we see now with mortality rates is that for every 100,000 women that are diagnosed, 31 women will die, Black women will die from breast cancer compared with 22 white women. And so before I start with Bellevue, which is where I work, and if you look right, I don't know if you can see, there's a little, see that little purple dot, that's NYU right there. So they're literally separated. The two hospitals couldn't be more different, but they're literally separated by just 2 blocks. I'm going to backtrack and just start with this hospital. And this is another city hospital that's further uptown. Does anyone know this hospital, recognize it? I don't know if anyone knows New York. This is Harlem Hospital. And the reason why I'm starting with Harlem Hospital is because of a surgeon by the name of Howard Friedman. And Howard Friedman was a surgical oncologist. He did breast. And Harlem Hospital is affiliated with Columbia. And in 1989, as president of the American Cancer Society, he set out on these public hearings on cancer in the poor. And what he wanted to do was he wanted to hear from underserved patients and what their experiences were and their family members, as well as from experts who were taking care of patients who were underserved. And what he found was that poor people face substantial barriers to obtaining care, and they often do not seek care if they can't pay for it. They make extreme personal sacrifices to pay for care. There's fatalism about cancer, and that cancer education programs were often culturally insensitive, and that poor people endure greater pain and suffering. And now, when I went to medical school at Columbia, I just, not knowing anything about Dr. Friedman, this wasn't, I took the opportunity to do an elective with him and shadowed him and his navigators. It was just an eye-opening experience to see what he had done. And so as a result of these hearings on the board, he came up with the concept of the patient navigation program. And he really wanted it to be, he designed it to be as a way to improve screening for breast cancer patients and to ensure that abnormal results were followed up to resolution. And through the identification and barriers and navigation services, he hoped to prevent mortality rates in Harlem. And so this was his original model. It really was just outreach. The navigator then would take a patient that was diagnosed with breast cancer, make sure that that patient got their diagnosis, got plugged in with treatment, and then their job was done. Obviously, that a definition of what a navigator does has been expanded tremendously, and has been, and now the navigation program has gone from prevention to diagnosis to treatment, all the way up to the whole continuum of care to survivorship. So now I'm going to bring you to Bellevue and our patient population, which is very diverse. And about 75% of our patients are either Medicaid or uninsured. Self-pay means uninsured here. And another 17% are Medicare. It's highly diverse. About a third of our patients are Hispanic, another third are Asian, 10% African American, and 9% white. And then 64% of our patients are immigrants. And then a third are US born. And they come from all over 149 countries. The top 3 are China, the Dominican Republic, and Mexico. So the first thing I do when a student comes in is I ask, what do you speak another language? Because you're going to need it. We have to use our navigators who are certified interpreters, or we use our dual set headphones. And they come from all 5 boroughs. And this is our cancer team, which is probably similar to your team, including, and also we include our legal services, who usually helps our patients with things like visa services and housing and things like that. So that navigator is a really key component, because they're going to be the key between the patient and our medical team. And so they're going to help with assisting with communication between the patient and the provider. They're going to help to surpass barriers to healthcare, offer outreach, serve to services and educational programs, as well as offering culturally and linguistic linguistic appropriate assistance. And so around 2016, we had the opportunity to think about how we can really have a true navigation program that we thought could really bring a vigorous focus to reducing barriers to and disparities in excellent screening and care for medically underserved women. And so this became the B. Welters Breast Health Outreach and Navigation Program. And as background, Mrs. Welters herself was an African-American woman who was a breast cancer survivor who was treated at NYU and was really concerned that she didn't see a lot of patients that looked like herself. And so she wanted to give back to the community. She herself had an interesting background. She was born at Kings County Hospital, which is another large city hospital in Brooklyn. She was an orphan as a child, and she felt that she and her husband really do a lot of philanthropy, both to a lot of other agencies and children, but also within NYU. And so after having a lot of discussions with her, we thought that this would be the best way to do this. And we really wanted this to be state of the art and something that could be a model for other academic centers. And so to achieve this mission, we had three prongs to this. The first was outreach. And by leveraging and building the relationships that we had with community-based organizations and placing culturally congruent navigators at places like churches and salons and other community sites. And then education, developing and distributing educational materials. And then lastly, navigation. And we leveraged the existing colon cancer navigation program that my co-director had done with the barbershop program and getting men to go for colon cancer screening. And the goal was not just to navigate to screening, but also through the whole continuum, and as well as clinical trials. And underlying this was research. So before we did this, we did our homework. We wanted to do a landscape analysis. So we looked at other programs throughout the country, even visited some of them. Mrs. Welters came with me on some of them. And we looked at what some of the other programs did. Some of them focused on within the hospital, or hospital-based, and focused on just screening within the hospital as soon as the patient entered the front doors of the hospital, and some of them were just focused on community outreach and then handed off the patient to the hospital, and then their job was done. We didn't want that. We wanted to do the whole gamut. We wanted to go out into the community because we realized that by just waiting for the patients to come to us, we were missing a whole population of patients. We knew that in New York, compared to other large cities, our screening rates were fairly decent, but we knew that there were large pockets of the population that we were missing, and we were not going to get to those patients or those women if we were just going to sit and wait for them to come to us, that we needed to go to them. And that's why we really vigorously fought to make sure that our navigators would go out into the community, and not just go out into the community, but handhold them, meet them where they were, and go with them through the whole process of screening, follow-up diagnostic services. And then if they were diagnosed, they would follow them through the whole process. And so the flow chart was like this. We have the community-based outreach and education. We navigate these women to screening services. And then if they needed diagnostic services, they were navigated to one of our sites, either NYU or Bellevue. And then if they were diagnosed with cancer, they got access to the latest treatments, clinical care, enrollment in clinical trials. And I'm going to talk about that as well, and supportive services, which we also receive funding for. And then the goal is to get them onto survivorship. And along with the funding from Mrs. Welters, we got some other funding from some other board members from the Cancer Center and external funding. And we launched in the fall of 2016 at the Brooklyn Botanical Gardens. And we chose that for a reason, because Brooklyn was where we felt that that was where the greatest need was, and geographically close to NYU. And so we launched it there, and that's where we were going to focus most of our resources in. And so you have here, this is a, I don't know if you see my marker, this is Mrs. Welters here with her husband, Tony Welters. We have some of our congressmen and women, Hakeem Jeffries, and this is our dean, Dean Grossman, and our Cancer Center Director, Ben Neal. So we had a lot of institutional support as well. And so what we did with that is we knew that wasn't going to be enough. We're always thinking ahead about how do we continue to sustain the program, and we leveraged this initial idea and from Mrs. Welters to write a grant to get some additional funding from the New York City Department of Health, and that allowed us to expand this program to hire additional navigators, and which allowed us to further expand into our New York NYU's family health clinics, which are very, very expansive within Brooklyn. And so we had navigators that would go into the primary care sites and recruit for patients that needed screening right in the family health clinics as well. And so this is our geographic reach. And as you can see, we're throughout the whole city. We have navigators up in Harlem as well as in Queens, but our real focus is really in Lower Manhattan and Brooklyn. And we also have an oversight committee. We meet with them once a year. We're hoping we'll get to meet in person this summer. And we have people both within NYU as well as outside of NYU that we give an annual report and get feedback on. And so it's been very, very helpful to do that once a year. We developed tailored material. We talked about health literacy. And the first year, we developed materials in English, Spanish, and French. And then the second year, we developed materials at a 6th grade level, all these materials in Mandarin, as well as in materials to target the LGBTQ population. We also have videos. We think that sometimes patients absorb things better when they can also see what you're telling them. So for instance, when we talk to our patients about the surgeries that they're going to have, we also have them we also have videos available that our navigators can also review with them after we speak to them. And they're translated into Chinese as well as in Spanish. So we have a video for sentinel node biopsy, for mastectomies, and also for lumpectomy. They're quick, they're 1 minute, they're animated, and there's something that they can look at as well, because we can talk about it as much, but sometimes when the patient can really visualize, when I tell them they need a mastectomy, sometimes they'll say, are you taking all the skin? And we're like, no, we're not. And so they can understand what we're doing. And so I'm just gonna play one of the videos. This is one in Chinese that we have.
乳房切除手术。什么是乳房切除手术呢？乳房切除手术是指将整个乳房切除。现在我们看到的是患有肿瘤的乳房。主刀医生首先会在乳头周围切开一个孔。主刀医生会取下乳头以及所有内部乳腺组织。胸壁的所有乳腺组织都将被切除，只留下外层皮肤。然后主刀医生会将乳房皮肤缝合，使您胸部这一部分保持平坦。好消息是您可以接受乳房再造手术，届时主刀医生会造出一个与您的另一个乳房相匹配的新乳房。再造乳房可以有几种方法，我们会在您决定做乳房切除手术后给您详细介绍。
And we have for Spanish as well. We've developed new partnerships that have also allowed us to expand our reach throughout New York City. And then again, we make sure that all our navigators get standardized training. And they also do barrier assessments for every patient so that we know how to focus the social determinants of health. So they go over things like whether or not the patient needs help with food insecurity, housing insecurity, transportation challenges, mental health, exposure to violence. So I tell them, just like a doctor needs to do an H&P, they need to do a barrier assessment, and all of that is documented in the chart. So this is an overview of the barrier assessments that our navigators have done. This is like over 580 patients, and over half of the patients are worried about missing their doctor visits due to no transportation. They need help reading their medical materials. 20%, 25% of them have a friend, do not have a friend or relative unable to take them to their doctor's visits. They're worried about their income not covering their living costs, or housing instability, and it goes down to like being depressed or hopeless, alcohol use, and signs of depression. So these are all things that we're capturing and making sure that these patients get referred to the appropriate services that they need. The other thing that we've done with this program is we partnered with the New York State Department of Health Cancer Services Program, which is a program that provides cervical, breast, and colorectal screening for uninsured and underinsured patients. And what we did was we asked Bellevue to sign a contract with the New York State Department of Health so that we can capture patients that are already coming to Bellevue that meet these requirements. The patients are already coming into Bellevue and need to be screened, and Bellevue wouldn't be necessarily being reimbursed for this. So now with the contract, New York State charges at Medicare rates. So what I do is I have a NP that does the screening for all 3 cancers, and with the contract, Bellevue gets reimbursed for this, and then we also get the credit for our program. So we have this, and it's also like a one-stop shop, because what happens is we have slots in mammo. The patients go right from mammo after they get their breast exam, they get their pap smear, the men get their fit kits. And it's actually, these patients are referred directly from primary care, and the primary care physicians like it too, because it's one less thing they have to do, and they get all the results uploaded in Epic. And we will follow up with these patients as needed. So it's worked out very well, and any patients that are diagnosed, and if they meet the Medicaid eligibility, we can enroll them in the New York State Medicaid Cancer Treatment Program. We've also expanded access to clinical trials, and we hired a clinical trials coordinator, and we had launched a comprehensive pre-screening program in 2017. So what happens is all the charts for clinic are pre-screened for all our clinical trials. 100% of our patients in our program were pre-screened. We launched 13 new trials for breast cancer, and 81 patients were accrued to the trial, which were 25% of all of our breast cancer accruals were navigated by our navigators. And the trial spanned the whole continuum from prevention all the way to metastatic trials. And part of that too is that we use our clinical trials coordinator to do physician and fellow clinical trial education. So for every new trial that opens, they train the navigators as well as the fellows on the trials so that they can speak to the patients about the trials, and that has helped significantly to increase clinical trial enrollment. We also designed a new data management system. So we have a specific template for cancer-specific patient navigation, and so our navigators can document all the work that they're doing, and then we can always go back and get the data from that. So we have all our outreach encounters, their barrier assessments, the community resources that are provided, and health outcomes are all documented there so that we can document the work that they are doing. And so we can run reports right through Epic. And then the plan is then to expand this to other disease sites as they come on board. Hopefully lung will be the next site to do this. And so we also increased our access to genetic counseling at Bellevue. We hired a genetic counselor under the Welters program, and with the pandemic, most of it has been virtual, but it's somewhat hybrid. And she also runs support groups for high-risk patients, in various forms, some for the LGBTQ as well as for men as well, and for people of color. We have a pretty high positive rate in our population. It runs somewhere around 13 to 14%, which is somewhat higher than the average positive rate in the country. So this is our 5-year impact rate. This is year 5, actually. We've reached out to, and this was last year during the pandemic, we did health outreach to over 1,200 women, enrolled 549 patients, and then navigated 305 patients, and navigated 87 patients, cancer patients, and enrolled 5 into clinical trials. And they did 12 educational events because of COVID. But over 5 years, we provided breast health education to over 19,000 women, enrolled 2,700 into navigation, navigated 1,300 into to breast health appointments, and enrolled 232. One of the unintended consequences of this program is that as the word got out about our program, other organizations started to send us their cancer patients. So it became not just a screening program, but it became a referral program, because people began to say, hey, you guys know how to get your patients through. We have other patients that are uninsured that need help, and we just diagnosed her. Can you take this patient? So we also started to get cancer patients from other programs in New York City. And so these are our patients. They come mainly from Brooklyn and Manhattan, and they're predominantly Black and Hispanic. 48% are Hispanic. And they're of the age group that you would expect when you're doing screening, or women who have cancer. So they run between 45 to 74. And so these are some of the women that we have navigated. This is Carol, who was a breast cancer patient, and they talk about the relationship. They form bonds with with their navigators, because they're with them all the time. They go to the appointments with them, not just the surgery appointments. They go to the med-onc appointments with them. They go to the plastics appointments with them. So the radiation oncology appointments. This is another patient who was turned out she had a BRCA mutation carrier. So these are our senior navigators. This Sheila, who's at the top, was our very first hire. We stole her from the American Cancer Society. And Jackie speaks not just obviously English, but she's also fluent in French, Haitian Creole, as well as Spanish. So she's our secret weapon. And some of our other navigators, Allah, who's Arabic, and Neftali, who's bilingual in Spanish. And we do a lot of outreach. This is one we actually did at NYU pre-pandemic. And Mrs. Welters, who also is always willing to speak about her own personal experience. We have a breast cancer and women of color event annually. And this is one of our FHCs in Flatbush in Brooklyn. And former Mayor de Blasio came with his wife, Charlene McCrae, to meet the staff. And we continue to share our best practices and increase our program visibility over the years. And I just want to share a little bit about how COVID had an impact, because clearly we kind of work on trying to do this one-on-one, and we had to pivot because of COVID. So what we did was, we first of all reached out to a lot of our community partners, because they were struggling. And so we tried our best to take on as many of their patients as we could. And we reached out to many of our existing patients to see how we could help them. And we tried to help them as much, because a lot of the social determinants of health were even more amplified because of COVID. And with screening shut down, once screening reopened in 2020, we had to re-engage these patients who needed to have their needed to be screened. So it was a challenge, but we were able to figure out ways to overcome the challenges of navigating patients remotely. And so last year, 2021 was really, I thought, a year of what we said was resilience or finding new ways to overcome this. We actually found that when we compared the same time period from 2019 to 2020 to 2020 to 2021, we actually saw a 31% increase in our screening completions, and interestingly enough. And we think some of that has to do with the fact that the mobile vans were still down, so that helped us increase our numbers. And when our navigators call these patients and say, hey, you need to get your mammogram done, they're also able to not just navigate patients to our institution, to NYU in Manhattan or NYU in Brooklyn or Bellevue. They can navigate them anywhere. They can get them an appointment anywhere in Manhattan. So if the patient says, it's not convenient for me to come to NYU, I'd rather go to Mount Sinai, or I'd rather go to Kings County, they're like, no problem, we'll help you get that appointment. And while they're on the phone, they'll talk to them about, do you have any questions about COVID? Did you get your vaccine? Things like that. So they really do engage them and build a relationship that I really do think, at least we think, we can't prove it, we think it helps increase our success rate. So for the future, our reflections over the past 5 years, as we look back, we really think that engaging and building trust among people who live in underserved communities takes time and commitment. Joe and I, Dr. Ravenel, who's my co-director, who's also in pop health and on the medicine side, we both of us have done a lot of community outreach and they've done this for a number of years. And so we knew a lot of the community organizations and we built that trust. They may not necessarily have trusted NYU, but they trusted us. And so I think that helps. And then you have to take it. And when you're building new referral networks, it takes patience and determinations, because they want to know, what are you going to do with our patients? Are they going to come back to us? Or are they going to get sucked up into the system? And so even though you're providing access to breast health, and that's what's going to attract the woman to the program, these women also have other comorbidities that are also going to need to be addressed. And that's the other thing, that they have other unmet needs that we also quickly found that you need to determine, and that then they also become a patient to your hospital. And so by providing assistance to women, by extension, you're providing assistance to their families. Also equally important is, and we were very mindful of this, is when you're navigating these patients, unfortunately, you will have a population of your patients that will die. And your navigators are spending a great deal of time and mental energy with these patients. It's going to take a toll. And at some point, and sometimes we had to have our navigators take a time out. We oftentimes would bring in people to talk to our navigators about stress and burnout, and make sure that they weren't carrying too heavy of a patient load, so that they kept going. And so sustainability is also something that's always on our mind. We wish that hospitals and insurance companies recognize the need for patient navigation, but this is something that is purely run on grant funding and philanthropy. And so we are constantly writing grants and trying to get philanthropic funding for this so that we can continue to deliver high quality care, navigation services. And we often will have navigators come from other programs to spend time with our navigators, so that they can see what we do. And we also want to advance the existing services and skills of our navigation team. We're in the process now of writing up a curriculum based on how we do things. It may not be right for every other academic center, but this is how we do it. And we want to make sure that also our navigators get continuing education just like anyone else, any other medical professional. So we're looking at the scalability of the program and how do we promote our best practices and develop toolkits and so forth. And we're looking at replicating this at the Perlmutter Cancer Center to other cancer sites. So we're working with the Cancer Center to look to move this over to the lung cancer model as well. And we're collaborating with our New York State to advocate for patient navigation reimbursement. We have, fortunately, during the pandemic, been able to get additional funding to hire more staff. And so we've added on a new PA and a data analyst, as well as an additional patient navigator. Our year 5 goals is really to increase our presence at the community health clinics in Brooklyn and to train community partners to screen patients for breast cancer screening eligibility to refer to us, and to continue to provide COVID-19 vaccination education, and to increase the technological capacity to provide telehealth navigation services, and to increase the use of telemedicine for genetics and provide virtual breast health education sessions. I'm going to just switch gears for a few minutes if I have the time, just to talk a little bit about the role that I have on the New York NYU Institute for Excellence in Health Equity, because I think that's pretty important, because we've been talking about, some of you have a lot of interest in this. And I want to talk about this institute that was launched at NYU a year ago by our dean in light of all the events that happened in 2020. And the IEHE, as we call it, is the vision was to strive for excellence in health equity research and clinical care and medical education. The mission is to be a leader in the development and implementation of evidence-based solutions to advance excellence in health equity, and to be a renowned magnet for diverse talent and an incubator for world-class leadership in health equity. So there's 4 pillars. There's research, medical education, clinical systems innovation, which I lead, and the community engagement and policy. And so these 4 pillars, which I'm not going to read, they're all built on a foundation of mentorship. And this is the leadership. It's run by Benga Ogadegbe. He's in the Department of Pop Health as well. Nadia Islam runs up the community engagement, and GM Medical Education is run by Dr. Ravenel, my co-lead for the Welters program, and Renee Williams. I would lead the clinical systems lead, and Antoinette Schoendaler, also from Pop Health, leads the research. And then we have some new collaborating faculty that we've recruited from outside institutions. So just to give you an idea of our DEI framework, this has been going on now for about a year and a half. And what we've done is we have 5 clinical vice chairs or associate vice chairs that were named by the chairs of psychiatry, radiology, surgery, pediatrics, and medicine. And then we have a basic science DEI chair. So these are the inaugural chairs. This has been really been supported by the institutional leadership. Fritz Francois, who is down here, is our COO. My thing. And then we have Daphna Barsagi, who's our Dean of Research, and Nancy Sanchez, who's our head of HR. So we all get together, we meet every other week to talk about issues with our respective department and how we are moving forward DEI at NYU. And we came up with a charter last summer. We literally had 3 full days of a retreat where we talked about how we're going to develop a framework for moving DEI at NYU in terms of faculty recruitment, retention, and this came up yesterday when we had the roundtable, and also promotion of URIM. And this is something that gets presented at the chair's lunch and also to the dean. And so we're working together. We're using a hub and spoke model. We're working together. IHE works with the Office of Diversity Affairs and the clinical departments, as well as the other the different medical branches, NYU Brooklyn, Manhattan, and Long Island, to move this effort across. And so for my department, I lead the Diversity and Health Equity Committee for Surgery and Transplant. And I have Marianne Hopkins, who leads up education and evaluation. I have Sapna Mehta from Reese, who leads up research. And then we have a recruitment, promotion, and retention subcommittee. And Sharice Berry, who's my trauma surgeon, who leads up clinical care access and health equity. And Jessica Gelber, who's one of our admins in transplant. And we really make it so that it's very diverse, and we include everyone from staff to faculty as well as residents. And then also on the health equity side, for the clinical systems pillar, I am working with the chief medical officer, the chief quality officer, and all the other senior leadership to deliver health and systems to identify and mitigate health inequities and achieve excellence in health equity outcomes. And so some of our goals is really just to improve the collection of patient demographic data and analyzing data on health equity across the care continuum. We're developing a dashboard metrics for health equity outcomes and modifying the EMR to better capture social determinants of health. And we're also eliminating race correction in clinical algorithms, which I'm sure you all are also tackling too. So we've gotten rid of like the EGFR and so forth. And so we've developed this whole process for developing the health equity dashboard, which is going to be finalized in a few months. The dashboard, from that dashboard, we'll develop a snapshot for every chair. And that chair, each chair, clinical chair, will then have to meet with the dean to go over whichever metrics are most appropriate for their department. And so what we're doing is we're working with all the different departments to go over ways to come up with health equity goals. And every department has to come up with 2 health equity goals. And we're going over how they can identify and determine the health equity goals by coming up with this research roadmap to target and eliminate health equities across NYU. And we've actually gotten some very interesting ideas that we are really amazed at. And what we want to do is not only have them do it just for the sake of doing it, but bring in the residents and the students and engaging them in this research by conducting and generating research questions, and then and identifying these ideas and implementing interventions, because you won't know how to solve these problems unless you evaluate these ideas. And so we've been partnering with these departments and guiding these departments, and then we'll evaluate the goals. And so IHE is basically the hub for all of this. And so I'm just going to close by saying that our research roadmap is providing a framework for collaboration across departments that we hope will lead to the development of large transformative research grants targeting health equity. So I'm just want to end by thanking the teams that I work with on the Welters side, on the Cancer Center side, as well as on the IHE side. And I'm going to end here, and I'm happy to take any questions. Thank you.
There's going to be lots of questions, I think, Dr. Joseph.
Okay.
That's great. Dr. Dubois.
Really an inspiring talk. I have a question about your navigation program, and specifically, I'm interested in the individuals who actually did not agree to be in the navigation program. Maybe you approached 1,200 and you got 380 or something like that. Do you know anything about those patients who you couldn't actually engage, and do you think there are opportunities to engage with them? Are those individuals, for instance, people who really have a distrust of U.S. health system?
Yeah, thanks for that question. That's a great question. That's something we're really trying to tease out, because we have people that they sign up. We go to a church or we go to a fair, they sign up, then we call them and they don't respond. And I think those are the ones we really want to get to. And we're trying to figure out how do we find out why. And I think those are the ones that really still just have this mistrust. But we're trying to figure out how do we find out why they just still won't come for their mammogram, because if they're not, no matter how, our navigators will call them several times, not just once, they'll call multiple times. And if they leave, if they agree to be text or, a text or something, they'll do that as well. The question is, how do we get to that, how do we answer that question? We can speculate and say these are the ones that are kind of curious, but they're still on the fence. Because if they came, they're somewhat interested to the event, but I think you're onto something, and which is what we're thinking too, is we're still not sure why it is that we still think they're still mistrustful of the healthcare system, and we still have more work to do. And we know we still have more work to do because when we look at the payer mix, we still have, while many of our patients are uninsured, we still have a large number that are still insured. So that tells you something.
Thanks, Dr. Joseph, for extremely motivating talk. Thank you for the charge in all of us. My name is Mark Stewart. I'm with the Trauma Burns. Over the last few years, and certainly even before that, a large proportion of our patients in the burn center are experiencing homelessness, and obviously it has deep roots in racism, economic disadvantage, and certainly amplified, I think is the word you used, because of COVID related to joblessness and evictions. And the proportion of people experiencing homelessness who are caring for in the burn center has increased in severity, and certainly over the past couple of winters been really fraught with frostbite, which has led to major amputations at unbelievable rates. So we're developing a very similar navigation program for a different condition. And I have three very related questions to the navigators themselves, and they're quite technical, so I really appreciate your expertise. One is, what sort of training resources nationally exist for navigators that might be validated to kind of get folks who are maybe have lived experience with homelessness gain ability to navigate? Two is, how granular have you found the importance of matching navigators to people that they're navigating, knowing that people experiencing homelessness are insanely diverse in all sorts of ways? And our question is whether how specific we need to be. And if we do need to be very specific, what salary structures have you seen or tried that may not be full FTE, for instance, but related to the panel of patients they're navigating and the time they spend navigating?
I'll answer this more from my perspective as a cancer person. So all our navigators use a combination of New York City has a training program, and then we have the George GW has their online training as well. And they get trained, we cross-train them, even though most of them are doing breasts, we also train them for colorectal as well, and then for also training them for lung, because we feel they should be trained in all subtypes so they can cover each other. And then, and just remind me your second question. Yeah, so we match according to a couple things. One is what the patient's, the language need of the patient. And also they cover, certain navigators cover certain sites. And then also if we think that there might be, some navigators are better at handling some more, what we would call patients that might need more attention. There are certain, so maybe the personality of the patient and the personality of the navigator. But certainly we start with that. So, but yeah, the navigators right now are location-based. However, if we do need someone to cover based on language or based on the personality of, like, for instance, if there's just, if it's like not a love match and it's not working out, it's not working out, and we're going to move them in. We switch it out. Yeah. Was there a third question or? Okay.
Dr. Mock and then Dr. Jav.
I've read several articles. I've seen several articles about navigators use of global surgery, like low-income countries. And mostly I get the idea they're unpaid volunteers. But these sound like they're actually employees of the hospital. So could you say a bit about their background, like high school diploma, college, what educational level
Yeah.
for, and how much do you pay them approximately?
Yeah, that's a great question. And this is something we are still, it still comes up every now and then because we have some navigators that have been doing this for a long time. We intentionally chose lay navigators. I mean, there's no definition as to what the requirements are for a patient navigator when it was first coined. So some places use social workers and some people use nurses. You really have to think about what the needs are for your own institution and what you want it for. But because we wanted to start out in the community, we really wanted people that could relate to the patients in the community. So we use lay people, and we specifically said we didn't care whether they had a bachelor's degree and so forth. We just wanted people that we knew could relate to the people. So some of our navigators, all our navigators have high school diplomas. And some have college degrees, and we actually have one that in the course of working with us got her master's. So they have varying degrees of educational levels, but they all are really good at relating to the patient population, which was what was primary for us. And then in terms of their salary, it really is based more on their level of experience. But for some of our navigators, in terms of us trying to get them promoted or getting them a raise, NYU being an academic institution will say, well, this person doesn't have a college degree. So we can't figure out, so we're trying to figure out different ways of changing the job description so we can continue to promote them. So those are some of the challenges when you're dealing with navigators.
Dr. Javin.
So much, Dr. Joseph. That was so inspirational, and I just applaud you for just a phenomenal career and trajectory, and how it's like driven by passion for this.
Thank you.
Partnering with the community. And I think one question I had mentioned at the beginning of your talk about wanting to lift up Bellevue Hospital's level of care to match or mirror that received by patients at NYU. And I wondered if you published data on looking at objective measures, whether it be receipt of genetic testing that's concordant with guidelines, or enrollment in clinical trials. Have you seen an uptick in those measures?
Yeah. Yeah, that's a great question. I need to publish this stuff, but I can tell you, so Ben Neal, our cancer center director, always likes to say at these meetings or when we have our retreats and so forth that I'll tell you our clinical trial enrollment is higher at Bellevue than at NYU. And it goes back to, I think we were talking about, the priorities. And so, at Bellevue, I mean, we're all salaried. I mean, it doesn't matter. We have the infrastructure at Bellevue, and we're all, we all have buy-in, and we're, all the stakeholders we're all committed to it. We talk about the clinical trials at our multidisciplinary conference. And so it's not it's just we just have a nice infrastructure for it. And so there's no other motivations. It's not like we're trying to get the patient straight to the OR to do the mastectomy or whatever. So we have the numbers may look smaller because we don't do as many cases, but by percentage wise, we enroll far more patients into clinical trials. And he's always loves and we also have shown that with the navigation, we've also reduced the time that it takes for our patients to get to the OR. That has really shifted because it's not an easy place to get through with all of the issues that our patients have. I mean, and that was one thing we really had to get NYU to understand, that our patients don't come wrapped in a nice bow like they do at NYU. Or they may not be like at NYU, this might not be their third opinion, but they come and we have to then get all their slides, get all the, to tell somebody whose English is not their first language, like you have to get your slides, you have to get your films. We have to do it. We have to help them do all of that. And then we have to get them the MRI and they need help with all of that. And it takes some time. So the navigators have been tremendously helpful in all of that.
Thank you, Dr.
Thank
Joseph.
you.
Well, I think you can see why we invited Dr. Joseph to join the day with us. And I just want to thank you again for an inspiring talk. You've given us stuff to think about. I can tell some of our faculty are already thinking about what are the lessons that they have here that they are considering applying in each of their programs. And my question was similar to Dr. Mock's, but I guess a more on the full pragmatic aspect of how do we sustain and grow those programs to make the business case for why patient navigation, and particularly the full service patient navigation like you've done, improves so many aspects of healthcare, but related to a topic that we've commonly crossed today, particularly in health equity and providing better access to healthcare for disadvantaged populations and individuals. So just before we break to lunch, I want to give a couple of thank yous, and I know that there's going to be a few more words at lunch, but a couple more thank yous. And the biggest one is for Allison Fiddler. Allison. It is not an overstatement to say that Allison is the brains and the brawn behind making today work. And this was seamless. This is the first time we've had an in-person meeting for 2 years, so we're out of practice, and Allison pulled it off and did it seamlessly. So thank you, Allison. And then to Dave Flum, you lead our research programs in the department. You're an inspiration to the other researchers in the department. You're so instrumental to organizing this day, you and the rest of the research group that you lead. So thank you for that effort. It's really appreciated. And I already said it a minute ago, but I want to repeat my thank you to the mentors, the faculty who are supporting these residents and fellows in the research that they're doing. The impact that you have is immeasurable. It's, as was stated earlier, you don't know how far the reach of that impact is. And then I'm saving the best for last. The residents and fellows who presented today, you were awesome. You were so great. I'm in such a good mood today after seeing your presentations, and it makes me optimistic about the future of surgery, the future of surgical science, and the future of the people that are transforming care for the future, as well as the people that are going to be taking care of me and some of the rest of us in the room. So thank you. We admire you and we respect you. We're really happy with the work that you're doing. So with that, thank you for being here for the Schilling Symposium. We'll have lunch, and there's some awards at lunch, right, Dr. Well, yes, thank you.